Dr. Mahmoud Osman is a gastroenterologist based in Tripoli, committed to advancing gastrointestinal health care. He serves as a clinical associate at the University of Balamand, UOB, and as chairman of the gastroenterology department at Nini Hospital. Alongside patient care, he actively contributes to clinical research and medical leadership. Dr. Osman helped introduce Tripoli's first fibroscan device, enhancing liver disease diagnostics with a safer, non-invasive method. His expertise includes advanced endoscopic procedures such as ERCP, spyglass cholangioscopy, endoscopic ultrasound, EUS, and endoscopic sleeve gastroplasty, positioning him at the forefront of minimally invasive treatments. Through international training, innovation, and academic engagement, Dr. Osman continues to elevate gastrointestinal care in Tripoli, recognized for his precision, dedication, and forward-thinking approach.
Thank you for this.
It's a real pleasure for me to welcome Dr. Osman and to moderate this exciting session dedicated for endoscopic treatment for obesity. I'm sure Dr. Mahmoud will give us interesting and promising results for these techniques. Fadal.
Thank you for this kind introduction, and it's a pleasure being here today. It will be a short presentation. I will discuss mainly the endoscopic management of obesity. Obesity is a health concern all over the world. مثل ما كانوا عم يقولوا زملائنا قبل بشوي, more than 1 billion people will be affected with this disease, and we should call it a disease. We are not bullying someone if we are telling him he's obese, so the mentality should be changed, and I think more people should be referred for weight loss management to the endocrinologist, to the nutritionist, to the surgeon. More people should be going there since very few patients are going this way. Only patients who are seeking their physique mainly are seeking weight loss management. Very few patients we are seeing, I think less than 10% are seeking medical care to treat their obesity. So as our colleagues were saying, like more than 1.3 billion, 1.1 billion people will be affected with obesity. Already obesity is a health concern all over the world, not only in the States, also in our country. And one thing we are seeing more often also that obesity in children, we should also highlight that obesity is affecting all age groups. So I will not go into details regarding the treatments, the oral medications, the injections, other treatments, but we have a lot of treatments and more and more patients should be recruited to be eligible to take these treatments. So the choice of our agents is basically largely in this area. We only look at the patient preference and what does he want. There's no strict guidelines on how to approach these patients because most of these patients, they came willingly to choose their weight loss management after seeking more and more information from ChatGPT, from Instagram and other places. So as a physicians, we should always recommend lifestyle modification as a first-line treatment for obesity. So eating habits is an important thing. We currently conducted a big study on intermittent fasting in Tripoli, and we enrolled a large group of people during Ramadan and during the Siyam Kaman, and we did like two groups, one group with intermittent fasting during Ramadan and the other group was intermittent fasting with vegetarian diet. And unfortunately, our data is not promising well, that intermittent fasting is not helping a lot, probably because of the lack of education, and we do intermittent fasting in a wrong way, probably. So intermittent fasting during the holy Ramadan or other Siyam areas, so is not working well with us. Physical activity, unfortunately, like more and more people are trying to be enrolled in physical activity, which is good, but still we are not having a lot of physical activity in our area, probably due to the lack of infrastructure and everything. So, and due to the lack of education, more and more we should involve our kids in physical activity, and we should allocate more time for this. So in addition to doing everything what you have to do, controlling your eating habits, doing physical activity, so there's a huge number of patients who are not able to lose weight despite every intervention they do. So these patients should be referred to a specialist. First line could be a general practitioner, could be an endocrinologist, but these patients should be seen, should be evaluated. As Dr. Taha was saying, this is a major risk on the patient because it can cause obstructive sleep apnea, it can cause diabetes, it can cause health-related risks, and it will increase the mortality of this patient. So these patients should be evaluated, should be seen, and should be referred from the dietitian or from the primary care to further help them lose weight. So I will not go through the surgical interventions like the rest of the group will talk about surgeries. Surgeries have been there for a long period of time. And I think we as a gastroenterologist, we are holding our horses for a long period of time, and we are not being involved in these techniques, probably because we are overwhelmed and we were very busy in doing the regular general endoscopy. And unfortunately, worldwide, most of the gastroenterologists are very busy, which is a good thing for us, but when you are very busy, you will work with the bread and butter and the easy work, and you will not do the hard stuff. And there is advancement in endocrine and gastroenterology and in endoscopy mainly and in managing diseases related to obesity, but unfortunately it's not being adopted. So we have a lot of new techniques, and we have a lot of new products in gastroenterology that very few people are using. I'm not talking only in Lebanon, and even in the States and everywhere. So the general gastroenterologists are very busy doing the regular endoscopies, so they are not doing a lot of other things. So when we say other things, I will not go through the pharmacology part. Already Dr. already talked a lot about it. So when we talk about endoscopic management of obesity, we have a lot of things. So you will hear a lot of things on the Facebook, Instagram about gastroenterologists offering Botox in the stomach, offering balloons in the stomach. And usually these also are available, and we will talk about the evidence behind them, and there's other things that we should also do. So what will make us think about doing an endoscopic management for obesity despite the well-approved surgical techniques? So we are not here to replace surgeons. It's a complementary measure for people who don't want to take the risks of surgery, or for people who are unfit for surgery, or for people who want something as a bridge for surgery. Sometimes morbid obesity, some of these patients are not a good candidates for surgery at all. They have a lot of risk factors, and they are not in a condition that allow them to do surgery. So these patients, we might be a bridge for surgery. Surgery alone and medication alone and anything alone will not help the patient. So I always tell the patient, like, our procedures is a bridge, or it's like a dafshil qadim. It will help you improve your general health condition. And even like, I think Halil surgeon will talk about the long-term effects of surgeries. So most of people will regain weight at some point in life. So general complications of surgeries, we all know. So that's why it came the idea of doing some endoscopic treatments. So I will first talk about the intragastric balloon. The intragastric balloon is like available since a long period of time. So we just go through the scope. We have a new generation balloons that don't need a scope. You can do it in your clinic. Although I don't recommend these type of balloons, as most gastroenterologists don't recommend these type of balloons that are not deployed using a scope, because we are not sure if the balloon will be stuck in a hiatal hernia or something like that. So if we want a balloon, I prefer to go with the balloon with the scope under vision and to put it in the stomach. So the role of the balloon, usually we inflate it with around 600 to 700 cc of fluid or air. So, and the role of the balloon will cause a volume reduction of the stomach. So it's occupying a large volume in the stomach. And although some people will think, okay, it's easy, it's funny, so it's low risk, let's do it. No pain, no gain. So this is it's a painful procedure. So that's why we as a gastroenterologist, we shy off putting a lot of balloons, because it's a painful procedure. Most of the patients will have severe pain in the first week. And the pain is usually due to the balloon weight and its heaviness, and usually patients describe it as the worst gastroenteritis they ever lived. So it's usually the effect of the balloon is only in the first week. You will have a very bad symptoms, most patients. Although the advertisement of the balloon, like usually we put it and then we tell the patient to go, you can do your regular activities within 24 hours, but the pain is usually, and the vomiting is very severe. Most patients will need an IV in the first 2 to 3 days because they are not able to tolerate a sip of water. There's a hack to this technique. So there's a new generation of balloons which we can prime the patient. So we, instead of putting the whole 600, 700 cc's of fluid in the first day, we can put like 300 to 400 of cc volume, and this will decrease the risks of side effects. And then we will do a rendezvous procedure in a month or a month and a half and add more volume, and this will decrease the side effects a lot. So this is in general the balloon. Usually after we put it, for the current generations are for 6 months up to a year. We have balloons that can stay there up to a year. Complications of such a procedure are very rare. There's few reports of pancreatitis secondary to the balloon compressing on the pancreas, but very few. Bleeding, very few. Of course, gallbladder stones, and with any weight loss regimen, there is a risk of gallbladder stones and cholecystitis. Migration of the balloon to the small intestine is also is a known risk. If the balloon is deflated or if the balloon is malfunctioning, the balloon might cross to the small intestine where it can cause a small bowel obstruction. So this is also as a very rare complication. So it can occur. So that's why when we inflate the balloon, we do a special dye. So when there's a leak of the fluid inside the balloon, the patient will notice directly a blue discoloration of his urine, and he will directly inform his physician that the balloon should be removed. So balloon is an easy procedure. It can be done by all gastroenterologists mostly. It's not difficult to do. The difficult part is to remove the balloon. And with the advancement of other techniques now, we have a lot of equipment that will help us remove this balloon. Okay? We should be aware that during the removal of the balloon or during the insertion of the balloon, there is the risk of aspiration and fluid and volume aspiration to the trachea. That's why during the endoscopy, it should be like a good airway protection during removal of the balloon. Some few reports of gastroparesis post removal of the balloon also, and this is like, we want this. We want the food to stay there for a longer period of time. We want the food to be undigested for a longer period of time, and that's the patient will feel more, satiety levels are better, and thus will lead to weight loss. So theoretically, it looks like a very good technique, but when we come to literature, so it's not working a lot. Unfortunately, the average weight loss with this technique is around 10, maximum 15 kilos. And usually Usually, alone, this technique is not recommended for everyone for weight loss. It has its special indications. So I usually, as all gastroenterologists in the world, we run away of inserting balloons. We don't like to put balloons to patients because the patient will continue to suffer for a few days. And after that, although it's not a very risky procedure, after that, they will not benefit a lot from the weight loss, only 10 to 15 kilograms. And we have exceptions. Some people who are binge eaters, so these patients do benefit from putting a balloon. Other techniques that I'm willing to talk today is about like endoscopic sleeve. So endoscopic sleeve gastroplasty, I will put a video. So it's a technique that we do like under anesthesia. We go through the esophagus to the stomach. And in this technique, we usually inflate the stomach first, and then we can mark with argon plasma. It's just a marker. So we mark the stomach and where we would like to act endoscopically on it. Then with a special tool that is usually it's fixed externally on the endoscope, we can start stitching the stomach. So usually this technique, also it looks easier on the demonstration. It's a relatively difficult technique endoscopically. You need to build your skills. It will make your stomach look smaller. And it works similar to like a sleeve gastrectomy that's usually done by surgeons. We can reinforce more so we can reinforce more stitches inside the stomach. And usually this technique will help usually it will decrease the volume of the stomach at least by 60%. So this technique have been there like for more than 10 years right now. So Apollo Group is working on it, and it's been advancing very fast. And initially the procedure was very difficult. The product was very bulky to be inserted on the scope and to be going through the channels. Now we have a new generation of products that are slimmer, easier to work with, and user-friendly. And it's being applied also in other areas of endoscopy. We can reduce hernia size. We can reduce, like in gastric bypass patients, if the stump is very big, we can put two more stitches in it. So this is advancing a lot, and this technique is promising a lot. Okay, so can it replace sleeve? For sure not. So also, we should understand our limitations. We are a bridge. We are halfway between Dr. Munzir and the surgeons. So we are in the middle. We help patients between medications and between surgery, and we are not here to replace surgery, because the effect of weight loss from this procedure is not comparable to sleeve. So it have a good weight loss, but it's not comparable to sleeve or bypass. So randomized trials have been done on this technique, and the mean body weight loss of 13.6% at 52 weeks was observed. About 1% of patients have complications. So although, yes, sometimes it could be higher in different groups, and the complications are usually bleeding or DVTs. So DVTs can occur with any type of weight loss surgery, and we should be aware of them a lot. Usually, most of our patients are young and healthy, and we can go quickly about it. So we have few cases who have had DVTs with sleeves and other procedures, like any hospitalization. So bleeding also is a major risk. It's around 1%. So during insertion of the needle is like the size of a 3/0 nylon almost. So during insertion of the needle, you can have bleeding. You can puncture a vessel. It can bleed. Usually we can control this endoscopically, And all of the studies that have been done, very few patients required transfusions. Okay, so from the 1%, around only 3% required transfusions. Other complications. So some people are worried about like these ridges might contain some food residue with time. So although this food residue will be there, it will be digested using acids and things like that. So there's no worry about, usually if we do a redo endoscopy after a few weeks or few months from the procedure, we will not find anything. Okay, it will be like a sleeve from inside. Is it reversible? So this is the most common question that patient asks me. So usually we are putting stitches. These stitches, we can remove them in the first 1 week, 2 weeks max. After that, the approximation of the stomach walls to each other, and we will have a permanent fixation of this area, and we will not be able to remove the stitches anymore. Can we do sleeve after we have did endoscopic sleeve arthroplasty? Yes. So as we said earlier, it's a bridge. It can be done before sleeve. It can be done after sleeve. So some patients after sleeve, they regain weight with time. And these patients, they are worried. They don't like to do surgery again. And they have the legitimate indications to do surgery. We might go inside and put some stitches, okay, to decrease the volume of the stomach. Other techniques that we use as gastroenterologists, as I stressing always, these techniques are easy to learn. We can, with few months of training, we can do them. Every gastroenterologist can do them. But we are busy. And that's why we don't have dedicated teams to do these procedures. We have a lot of techniques, a lot of procedures that can be done for weight loss. We have a stents, long stents that we can put from the stomach to the D3 to the jejunum. We have like endoscopic ultrasound, guided gastrojejunostomy. So we can, and this is like a bypass surgery. We go through the stomach, we locate the jejunum, and we can put like a stent through the stomach and the jejunum wall. And this is like a technique which is relatively easy, and we can create a bypass for these patients. Unfortunately, we as a gastroenterologist are very busy doing the regular stuff, and we need dedicated teams for these. But the future was here a few years ago, and it's still there, and we should like catch the train and do more of these procedures. So I will not stress a lot on the difference between the medications versus weight loss versus other. So we already talked about that. So our experience, we did like few procedures, endosleeve in Tripoli, and these endosleeve went very well. Our patient lost like more than one of our patients lost 26 kilos till now. The other patients is around 19 kilos lost total weight loss, and we are talking in few month period. So it's considered a huge success, and I think I will stress again, we are here not to replace surgeons and not to replace medications. We are a bridge in between. Few patients should have these procedures, should be evaluated for these procedures, and all patients should be educated about obesity and be referred to a specialist. Thank you.